Hello, my name is Shahan. I'm the head of product at a company called C-Mode, and I'm here to talk to you about AI-enhanced ultrasound reporting for breast and thyroid. So a little bit about C-Mode first and what we do. So we're a company focused on improving the speed and quality of ultrasound reporting, and we do that using AI. Specifically, we use AI to interpret ultrasound images, and we extract information from those images, we detect pathology, and then we generate some of the key content that sonographers and radiologists produce as part of that reporting workflow. And we believe that by doing this we can really improve report throughput and help with time saving for both sonos and radiologists. And our technology doesn't require any specialized imaging protocols or any specialized hardware. We work with standard ultrasound image series. So in terms of why we decided to focus on breast and thyroid in particular, these are some studies that when we talk to clinicians we consistently hear are time-consuming and complicated. And so part of that is due to the tech worksheets that are produced. They can often be quite difficult to read, especially if they're handwritten on paper, and they're often non-standardized. BI-RADS and TIRADS themselves can be subjective, and clinicians have different levels of experience when it comes to using those descriptors. And then even technicians themselves have different levels of expertise when it comes to capturing images of thyroid and breast scans. And this leads to a potentially significant amount of dictation time for the radiologist. And it's this dictation time we think that we can really bring down with our solution. So there are four main components to our solution. The first involves the automatic detection and classification of the lesions. So we capture all of the images directly from the ultrasound machine, and then from here we detect all of the lesions within the images. We automatically classify them using the BI-RADS and TIRADS descriptors. We will position a visual version of that onto a diagram. So everything you see here on the screen should be ready for the sonographer to review as soon as they have finished with the patient and gone back to their workstation. And this is produced fairly quickly, in probably less than a minute. Now once we have produced the content you see here, we go one step further and we generate a worksheet for the sonographer. And this worksheet is sent directly through to PACS or RIS for access by the radiologist. And this worksheet looks the same every time. It's consistent and it's very readable, and it's generated immediately. And then moving on from there, we also generate some of the radiologist impressions, which we then send through directly to whichever system is being used for the production of the radiologist report, whether that's PowerScribe or Fluency or anything else. And we send that immediately alongside the sonographer worksheet. Now the sentence structures themselves are customizable, so we understand that there's different preferences around how those sentences look and how they read, and so we support a variety of different ways of allowing them to be manifested in the final report. The fourth element of our solution is around follow-ups and comparisons. So there's a large volume of surveillance work done across both breast and thyroid. We have all of the patient's previous scans within C-Mode, and so what we do is we make it very easy for the tech to compare previous images of the lesions with new images of the lesions. And once they've indicated the new images, we will automatically look for changes. So those are changes with respect to the size of the lesion or the characteristics using BI-RADS or TIRADS, and then also the final assessment. So with those four value props outlined in terms of the key components of our solution, there are a number of things which come up in terms of questions from clinicians when we talk them through the solution. And one of those is around dealing with multiple nodules. So what do we do if there are a number of nodules visible within the same image or within the same images? So by default, models will detect all of the nodules. And so an example is up here on screen. We'll detect all of the nodules. We're able to distinguish between lesions and things that are not lesions. So even, for example, distinguishing between a cyst and the carotid artery in the image. And then we also have a number of rules which can be implemented based on the clinical protocol. So for example, if there's a desire to ignore lesions that are below a certain size, or to ignore cysts that are below a certain size, we support those specific customizations. Another scenario which comes up in terms of questions is around how we deal with the views of the same lesion across transverse and longitudinal views. So we are able to group images based on the presence of the same lesion across those images. If it's a split image, that gives us a much higher confidence that the lesion is the same across those images. But even if there is a single lesion or multiple lesions and they're present in entirely separate images across those different views, we will auto-group them. And that's important because effectively when it comes to identifying the most accurate classification, we know that some images will be better for representing certain biroids and thyroids features than other images. One question which often comes up is how we deal with, or how the AI deals with scenarios where the image quality is very different across different scans, or there's a large variety. And so what we do here is we ensure that we train our models using as broad and as diverse a data set as possible. And across these 4 dimensions here, so operator variation, making sure we have a data set which includes images captured by sonographers with different levels of expertise and across a large number of clinics. Vendor variation, so ensuring that we are supporting all of the major equipment manufacturers. Anatomical variations as well, in terms of the different patient and things like tissue density we see come up quite frequently there. And then finally, pathology variation, so ensuring the data set has a very broad range of pathology from less suspicious lesions all the way to highly suspicious lesions. And then finally, when it comes to nodule sizing and locating, which helps us position them automatically on the diagram, we essentially extract the location image off the annotation. So with breast, we can get quite precise due to the clock face system. With thyroid, we do our best with what information is present within the annotations, but then we also do allow the tech to use the interface to precisely position the lesion on the diagram as well. When it comes to sizing, we would default to extracting sizes off all of the calipered images, but we are also able to size nodules ourselves using the detection. So if clinics are open to the sizing being driven by us, that's potentially one less step for their sonographers to do when it comes to completing the scan. So I mentioned our AI a few times already, but just to, at a high level, go a little bit deeper, there's 2 main components to our models. The first is around our detection, so being able to find each of the lesions within the images, and this is something we do automatically. This doesn't need to be, it doesn't require any manual intervention by the user to identify where the lesion is. And then for both biroids and thyroids, we have individual classifiers for each of the different descriptors. And what our models will do is that they will output a probability for each of the values for a given category. And then whichever probability is the highest, that is the one that we are the most confident is the final value for that particular lesion. And then finally, I just want to briefly talk about where we actually fit within the workflow. So we're a cloud-based system. We automatically get images routed to us from a clinic's PACS, and then we are used by the sonographer to do the review of the worksheet that we've generated. Once they've finalized that worksheet in C mode, the reporting content gets sent through to the radiology reporting system, and then a PDF version of that worksheet, which I showed you earlier, gets sent over to PACS. And so the radiologists don't actually have to use C mode. They benefit from the data that we automatically send through once the sonographer has completed their work. And we believe that this is a way that we can improve the overall speed of reporting without having to disrupt any existing clinical protocols. So that's all I had for you today. Really appreciate your time. We are at booth 4853, which is conveniently just over to your left. Yeah, thanks again.